What I'd like to talk about is I'd like to present a profile of the patients that we see in the hospital I work in, Schneider Children's Hospital. I run a clinic for children with dual diagnosis, as I said, and before I do that, I have to give you a little bit of background. No, why doesn't it work? Okay. No, the handheld one worked even less. I'm very good at medicine. I'm not so good at technology. I'm going to present to you the problem that we're trying to deal with, what the solutions are, and only then will I talk about our clinic, and then I would like start a little bit of a discussion and feedback, and I'd like for this slide to move on to the next one. Okay, I'm going out over some well-worn ground, but I still think it's important to go over these things. Jeremy, actually, in this very room about an hour ago, said the same thing. Intellectual disability, by commonly accepted definitions, has a frequency of about 2% to 2.5%. That's important to note because in Israel, less than 0.5% are formally diagnosed. In other words, when we talk about in Israel the people with dual diagnosis, with intellectual disability, most people refer to the 0.5% figure and are actually missing about 75% of cases. Probably about a third of the people, children and adults who have intellectual disability, have additional mental health problems. Okay, and no, I've gone backwards. Thank you for noticing that. The people who provide help to these patients, I'm a doctor, so I call them patients. Can't actually see what I'm looking at here. Are A, psychiatry departments for adults and for children. B, we have a specialist unit in Schneider Children's Hospital in Petah Tikva that I mentioned, the picture of which you saw at the beginning, by the way, for those of you who paid attention. And there's a unit which was set up about 7-8 years ago in Beit Izi Shapiro, jointly by Schneider Children's Hospital and Beit Izi Shapiro. Two of its members, who are not even in the room yet, will be presenting on that, so I won't say a lot about that. Okay, first of all, about this thing of the generic clinics. Okay. If I've got a mental illness on background of intellectual disability, I can go to the local psychiatric department as a child or as an adult. Very nice. That's a model adopted in many countries. Does it work? Well, we don't really know. However, we did little studies. Shirley Werner, who also presented in this room about an hour ago, and a few others, including 2 people from the health ministry, did a survey of psychiatrists to see what they think about how it works. We published that about 2 years ago. And just giving you the conclusions, because we don't have time for the methodology or anything like that, but we got to about 250 psychiatrists, child and adult, which is about a quarter of the total population in Israel. We asked them, how do you think it works? It was a bit longer than that, but that's what it came down to. And basically we found a lot of evidence for inadequacy of service. The psychiatrists themselves were saying, we had no training in this, we don't really know what we're doing, we don't have any more senior colleague to turn to if we need any help. And a survey of the literature suggests that it's not just that it doesn't work here. This sort of model apparently doesn't really work well anywhere. In spite of all the talks we've heard about integration and mainstreaming, I think mainstreaming doesn't work for this problem, for mental health problems on the background of intellectual disability. Psychiatrists, psychologists who've been generally trained may be excellent. They may be very nice people and have a lot of sympathy for this population, but they haven't been trained in this and they're not going to pick it up along the way. There are very simple options for improving services, which we may talk about today if we have time. Okay, that's the background. Now, my unit. We treat children and adolescents with intellectual disability and mental health problems, as I said. We've been going since about 2001, roughly. We have psychiatrists and paramedical staff. The paramedical staff is 1 at the moment. It's unfortunately mostly psychiatrist-based. That's not for ideological reasons. That's just the way it works out. So the psychiatrists do a lot of the stuff that we would really like non-psychiatrists to do, and obviously they do it less well, but that's life. Okay, and we said to ourselves, I said to myself, I do a lot of talking to myself, who are these people? And what do they want from me? I didn't say that bit. So we didn't actually have any statistics, so we got some statistics on who we're dealing with, and I want to present those to you. We also looked a little bit in a very rough kind of way of how much we're helping them, and a few hypotheses about what correlates with what. The measures, we don't really have time to go into them, but we used behavioral measures. The ABC in particular is of interest. The aberrant behavior checklist, the second line, is a very commonly used instrument, 58 questions which the parents fill out, items about behavioral problems in this population by Michael Amen. The FAD, the FAD is a very commonly used instrument for For measuring family health or family functioning, the GHQs is a very general mental health measure. Eftersom gå til la the GHQ is used to assess minor mental health problems in adults. They fill it out themselves. And the Vineland is a adaptive behavior scale, a sort of funny kind of IQ test. Okay, we performed, we did assessments with these various instruments at 0, in other words, when people came in at 4 months, 8 months, and 12 months, and then the research ended. And these are the presenting problems. We had over half of the group came with behavioral problems. These are the expressions that parents came with. Behavioral problems, violence, hyperactivity, that's about 60%. And the rest were all kinds of other complaints. We had a profile of the patients who came. There was a high rate of physical disability. Now, this is not going to surprise anyone who has a little bit of experience in this kind of field. First of all, because intellectually disabled people have physical disability. And if they have physical disability, they're more likely to have psychiatric problems and present to psychiatrists. So the rate of physical disability was very high. We have here, some people had more than one. In fact, if you count, those of us who are not mathematically impaired will see that this is more than 100%, because some people had, you could easily have CP and epilepsy and be blind. No problem. So anyway, physical disability was very, very common. What did they get before they came to us? Almost 80% got psychotropic medication. I'm not talking about historically, I'm talking about in the time before they came to us, running up to the time before they came to us. And of those 80% who had psychotropics, most of them had antipsychotics, a few of them had stimulants. I suspect if we'd done this on adults, we would have found many fewer receiving stimulants and more antipsychotics. What did they have apart from medication before they came to us? Most of them had nothing. And that's not necessarily most of them had been through other hands before they came to us. It's not that they hadn't seen anybody at all. But if they'd seen somebody, they usually had no other non-medical treatment. A few of them had psychotherapy. A few of them had other non-medical treatments. None of them had behavioral therapy. I think that's quite significant in the fact that in my personal view, this, behavioral treatment is the single most important non-medical modality for treating with these problems. Intellectual disability, about half had mild and the rest had below. That is a slight skew downwards. You normally expect more to have mild intellectual disability. This probably reflects that those with more severe intellectual disability are more likely to get referred, more likely to have problems. And of the problems that we saw, about 1/3 had PDD, the rest had externalizing disorders, for instance, hyperkinetic disorder or contact disorder. About only 3% had no disturbance. In other words, to those of my colleagues who are not specialized in this field, of whom I believe there are none in this room today, if somebody comes to you with an intellectual disability, chances are, if you're just diagnosing the intellectual disability, you've missed the boat. People come to you because they have additional problems. Nobody's going to send a kid to you if there's no additional problem apart from intellectual disability. The behavioral problems that they had, the most outstanding ones were in the area of, on the ABC scale, of course, which has 5 different scales. The most common were in the irritability area, and that seems to be what bothers parents most. Stereotypy was also outstanding. And although they were also, okay, I'm going to keep running. Where did you get that so quickly? Okay, we only recommended to 20% of children antipsychotics, and in overall medication only to 60%. Note that we recommended much less medication than the people who'd been seeing them before us. And in over half we recommended family therapy or some kind of work with parents. In other words, only 20% did we not recommend any kind of non-medical intervention. So this is almost a turnaround of what patients had come to us with. So we had a number of hypotheses that the relative adaptive level would be inversely correlated with behavioral problems, which actually turned out to be true. The lower the children were, in other words, the lower functioning, the more problems they had. We hypothesized that the lower the adaptive function of the children, the higher would be the level of parental mental health problems as assessed by the GHQ, and that turned out to be right for mothers, but not for fathers. That's important. Fathers, these things go by them, at least apparently. We hypothesized that kids would get better over time after a year, and fortunately that was the case, at least on the irritability scale, which was the main problem, and also on some others. But that's not good enough. We didn't see improvement on all scales. And we hypothesized that the greater parental ill mental health, the greater the family disturbance would be, and that again turned out to be for mothers, but not for fathers. Again, these things just pass off the fathers like water off a duck's back. Thankfully, most patients were satisfied or very satisfied with the treatment they received, and so that's nice. Of course, we'd like to be 100%, but 80% is not bad. So to summarize, we had more single, I'm obviously summarizing some things I didn't have time to present. We had more single-parent families than one would expect. We had a high rate of physical disability. We had the main presenting problems were behavioral problems, violence, that kind of thing. Many patients, most patients had come to it with prior treatment of psychotropics, and very few had come with any other treatment than psychotropics. 2/3 of the cases had PDD. Most of the presenting problems were in the realms of irritability and stereotypy. Families functioned in the stressed range according to the FAD, the family measure that we used. We used less antipsychotics and more stimulants and more non-medical interventions than our predecessors. As I said, the low functioning of the child, the more there was irritability, lethargy, and stereotypical problems, and they were correlated with mother's mental health problems. Perceived family functioning is correlated with maternal but not paternal mental health. Patients got better in the area of irritability over a year. Parents were reasonably satisfied. Limitations are plentiful, and I'm not going to dwell on them. Let's keep going. Tentative conclusions. This is a sicker than normal population in the physical sense. We used less psychotropics, less antipsychotics, more non-medical interventions. Keep an eye out for parental mental health. It's a problem. It may not be that obvious. It's certainly going to influence your treatment. Keep an eye on gaps between parental mental health and between parents' perception of family functioning, which can be very important in knowing whom to speak to and how you speak to them. And we need to find ways of improving things other than just the irritability. So to summarize the summary of the summary, dual diagnosis is common and poorly treated. Non-specialist psychiatrists need to keep in mind non-psychotropic modes of treatment. Specialist care can be helpful, is appreciated. As I said, we need to keep in mind parental mental health and family functioning and be nice to dogs and little children, most important. Thank you.